Good afternoon and welcome everyone. My name is Karen Lee and I would like to welcome you to the California Improvement Network, or CIN webinar, Creating a Lean Culture at Family Healthcare Network. Just a little bit about the CIN. It was established by the California Healthcare Foundation as a social network to share ideas about improving the delivery of chronic disease care. We host these monthly webinars to share better ideas in improving the quality of care, optimizing the patient experience of care, and or reducing the cost of care. Since we anticipate many people joining the webinar, everyone has been muted. If you would like to ask a question, please send me a question through the chat function, which is towards the lower right part of your screen, or you may use your raise hand function, and I'll unmute your line so you can ask your question directly of the presenters. And the presenters are happy to take questions throughout their presentation, so feel free to ask a question when you have it. I am delighted to introduce our speakers today from Family Healthcare Network, Dr. Stephen Palmer, who is the Chief Medical Officer, Mr. Jay Kelly, who is the Chief Information Officer, Ms. Norma Verduzco, Director of Operations Projects and Support Services, Ms. Marisol de la Vega Cardoso, Director of Quality Improvement, and Ms. Adriana Carrillo, Enrollment Referrals Representative. And I'll hand it over to the Family Healthcare Network team.
Good afternoon, everyone. My name is Marisol de la Vega Cardoso, and I am the Director of QI for Family Healthcare Network. First, I just want to thank the CIN Network for having us present today. The other team members will also be speaking throughout the presentation. The main objectives of the presentation today are really to learn how we implemented this lean approach in our ambulatory care setting, also some of the benefits of lean healthcare, as well as how we used a lean approach in the implementation of our EHR this year, and where we really had no decrease in productivity during our implementation process. Just a little background on who we are. Family Healthcare Network is located in Central California. There's a little map on the screen there. We serve two counties, Tulare County and Kings County, and we've been serving the area for 34 years. I provided a little bit of background as far as our sites. We have 11 clinical sites and 2 administrative sites. Last UDS year, we served approximately 101,000 plus patients and through 492 plus encounters. We provide a variety of services, and so we'll be talking a little bit more about how, through the implementation of EHR, we dealt with those various services. First off, I just want to talk a little bit about what lean is to us. And really, lean is just a set of concepts, principles, and tools used to create and deliver the most value for the customer's perspective while consuming the fewest resources. This is something that we use throughout our improvement processes, and when we think about reviewing current processes, and again, we'll be talking a little bit more about this. But overall, it's really about overall performance of the organization and not working in silos. And I think that will resonate throughout the presentation today. I'm now going to pass it on to Dr. Stephen Palmer, our medical director, and he will talk about how we initiated this process.
When we decided that we would go lean, we were looking at the various things that we did on a daily basis, and we wanted to see what we could do better and more efficiently and a little bit more cleanly. Lean was a concept that was introduced as a program at the Toyota company in order to improve the quality and the production of motor vehicles, and has been translated for a number of different uses. Lean for healthcare was just one of them. I had the pleasure of reading a couple of books about lean and thought that it would be a good idea to see how we could implement it into our service and system. What I saw was an opportunity for us to improve how we did things, the ease with which we could do things, the amount of fat that we had in terms of almost everything that we did, from registering patients to doing our daily work activities, the number of forms that were required to do all of this stuff, the number of hoops we had to jump through to get from point A to point B, and the idea of leaning it seemed reasonable and obvious to me in terms of how we could best reach an endpoint of efficiency. We wanted to also have the opportunity to do something new and different that would be helpful, that would be efficient, and that would make the lives of our employees easier while serving our patients better. And Lean fit the bill for that. The two books that we used were Lean for Practitioners. The first one was called Lean for Practitioners. The second was Sustaining Lean Healthcare Programs. Both of them were written by Mark Eaton, who is British. They're both available on Amazon.com. They're relatively inexpensive. As a matter of fact, last time I looked, I think they were $7.12 each. And they really are a good start. We had all of the senior leadership and then the other leadership in our organization read the books about Lean so that they had a good concept of what was going on. And then we made the decision to put the Lean program into place. I'm going to ask Norma to make some comments about how we did that.
We wanted to make sure that we introduced the Lean concept at the ground level. So we also understood that it was important that as an organization, the Lean concepts were understood as well as accepted. So like Dr. Palmer said, it did start at the senior leadership and leadership level. It trickled down to the supervisors level where they were asked to also read the books, and we had discussions about the books and the concepts so that everybody was on the same page in terms of what Lean was all about. And then came the point where we needed to put Lean into practice. And we did work with a consultant who was a black belt in Six Sigma Lean methodology, and she came on board to support the organization and really introduce the Lean concept. She worked with the, quote, Lean team members in that capacity, and some of us had the opportunity to sit in the sessions to kind of see firsthand how the concepts were put into practice.
One of the most important things that we did in establishing a Lean team was to take frontline individuals who were not afraid to say what was on their mind and make them part of the Lean team so that we could find out from a first-hand point of view, not from a leadership point of view, and not from an abstract point of view, what was working, what wasn't working, and what we could do better. And the Lean team was made up of all different frontline people, including medical assistants, referrals personnel, there were physicians, there were mid-level providers, there were appointment reps, there were our appointing folks from the what we call the central appointment representatives. We had a little bit of everything so that everybody had the opportunity to feed into the Lean concept.
So on the slide that says establishing a Lean team, engaging staff, at that point the supervisors were aware of what the Lean team was all about and where the organization was heading. They were asked to nominate staff from the different clinics, and we have 11 clinics and the different functional areas. And there were certain criteria that was given. We wanted to make sure that the staff that were nominated were knowledgeable in their areas, that they were not afraid to speak up because obviously they were going to be driving organizational changes, and they were open to change. So given that criteria, staff were nominated, and we came up with our lean team member that was completely multidisciplinary and was truly a representation of all of our clinics, whether it was a small clinic, rural clinic, or if it was one of our bigger hub sites. The consultant did use a hybrid of an actual Lean Six Sigma project, and one of the biggest things that she did was the DMAIC model, which we'll get into in the next slide. But we wanted to make sure that there was activities that really produced quick hit processes that we could retool and really use to eliminate waste and begin to streamline our operations and our processes. So some of the things that came away from all of those activities and the consultant working with our lean team was streamlining how we scheduled appointments and the scripts that were being used, wait times associated with getting an appointment and waiting to be seen, as well as the completion of the paperwork. In the slide that reads General Lean Six Sigma Methodology, the DMAIC model was basically one of the major concepts that she used. And basically DMAIC is the Lean Six Sigma version of PDSA. And D is to define the problem, and there's two activities that were used to define the problem. One of them was voice of the business, and what we did was we had just completed an employee satisfaction survey, so we used comments from that survey to really help define the voice of the business or the voice of the employees. The second one was the voice of the customer, and we had patient satisfaction surveys that we looked at, and those surveys had specific questions, or had, they still do, have specific questions that revolve around wait times and processes, and they also capture verbatim comments. So that was one of the tools that we used. And the second tool that we used is we did a specific survey with 100 patients that had just been seen in the last 2 weeks. And basically when we polled the patients, it was very open-ended questions: what's working, what's not working, or what have you seen in other clinics that you would like to see at Family Healthcare Network, and just general comments from them. And all of this feedback, all of these verbatim comments were basically broken down in activity, and they were basically separated out into themes. So if there was a comment related to customer service, it was put on that theme. If there was a comment about our wait times, for instance, it was put together. And all of that feedback was used to really guide the team in terms of what our customers were needing from Family Healthcare Network. M is to measure the problem, and what we did here was we looked at data. We had existing no-show data, we had data about cancellation appointments, we had data on wait times. We did a value stream mapping where we went to one of our clinics, and for each of the reception areas we did a process, what she called process mapping of from the time the patient comes in to the time they get pulled back into the exam room, what was each reception area currently doing, and as a result of that mapping, what was truly value added to the patient. And so the workflow was looked at from what are we currently doing, and then what should we be doing that really adds value to the customer. The A is for analyze for and isolate the root causes. So we looked at what were the customer requirements, and we looked at the data to analyze it in terms of our hypothesis, or what are some of the things that we really felt needed to be changed. The I is really the improvement piece of it, and you're looking at to target the root causes of what are the changes that need to happen, and what are the causes of all the processes that really are not value added to the customer. So the goal there is...
Norma?
Yes.
Oh, I'm just wondering if you could provide an example of what a customer requirement is.
So if a customer requirement is that when they're coming in to be seen, they really don't care for the forms. their need is to come in and see the provider and take care of the medical need. So that kind of triggered us to look at the forms and really determine what is it that is really required of the customer because it's a business requirement or something tied to a grant, and what is really not needed because it's being captured in a different format.
Also, Karen, another way to think about it is, what would a customer pay for versus not?
Oh, great. That's helpful. Thank you.
And then the last one is to create control plans to measure and keep the processes that you implemented fixed. So that's in a nutshell the DMAIC model, and it's one of the concepts that came out of Lean. Using the value stream mapping process, so again, looking at the processes, looking at our workflows, and we did a lot of this as well with EHR, and Jay's going to get into those specifics with our workflows because, again, we looked at what were we currently doing, and then what are those things that are value added to the customer that the customer is willing to pay for, and what are those things that we could automate or take care of in a different format. And we looked at what was non-value added, in other words, the fat that Dr. Palmer referred to and the waste. And again, those business requirements that were essential to Family Healthcare Network, but not necessarily adding value to the customer. The goal was to maximize the use of our systems and really facilitate the pull-through of that patient throughout the clinic, throughout the patient visit. Some of the benefits that came from value stream mapping was it really helped us understand how the processes were working for us currently. We had a multidisciplinary team, so it created awareness for that medical assistant of what the receptionist went through. It created awareness for the referral clerk of what it entailed to schedule an appointment, for instance. So it just created an awareness, and you had different people from different departments engaging and providing feedback and input into what the final workflow would look like. It helped uncover waste and problems in the flow, and it really allowed people to reach agreement on what changes needed to be made. And we were all thinking lean. I'm going to hand it over to Jay, who's going to talk about the case study specifically to our electronic health record.
Good afternoon, everyone. Basically, we hadn't at first anticipated using Lean as part of our EHR implementation, but after the success we had with it initially, we thought that it just blended just perfectly with our EHR implementation. It became one of our core teams. We had 4 teams, a build team, a design team, a core team, and a Lean team, and all of them worked together during our implementation, and overall it added to the success of our implementation. Our first slide is the project plan at a glance, and this kind of shows our 1 year of our implementation from kickoff to GoLive. We, through the entire project, you can see that we had a communication campaign. This was to keep staff engaged and informed. It was also one of our strategies by having such a large team. We had over 45 people in our implementation, and the idea behind that was that when they would leave the meetings, whether it was design, build, core, or Lean, they would bring information back to their areas, share what our plans were, kind of keep staff engaged, and also to bring ideas back to their team when they returned. So we maintained this throughout. We had all kinds of different things. We had contests. We had information for patients. We, even did little things like screensavers, just keeping staff informed of what our timelines were. Throughout the build, this is where Lean team really came into effect. Everything that was built, with all EHRs, you receive several templates or forms from your EHR vendor, and when we received them, we thought this was going to be great, and then we actually tried to look at them, and they were terrible. And so it was part of our group's decision that we were pretty much going to rebuild everything. And so in this rebuilding process, Lean was huge. They tore things apart. They tried to find where there was waste in the system and how we could, lean those out and how we can be more efficient. And again, this kind of all contributed to what we're seeing today. And when I get to some slides and a few things up, you're actually going to see our production and how it's maintained throughout from the date of our EHR GoLive and ongoing. We did several things in our EHR. We tried to get hardware out as early as we could so it would minimize providers' frustrations with learning not only an EHR but also new hardware. We worked very hard on making sure that our builds were correct for our templates and for our forms. We did several testing, tweaking, confirmations of things to make sure that everything would work like we anticipated it would. And then we got down to the point where we were at a simulation in September. We thought we were feeling pretty good about ourselves. We broke up into groups, went all over our sites trying to figure out, how this is really going to work. We were high-fiving each other going into this, and by the end of the day, we were job searching. So it was kind of a disaster. Everything fell apart, and we realized we weren't as good as we thought we were. We went back to the drawing board. We made sure, we started looking at what might have gone wrong, and we realized, we kind of just bought into our own system a little bit too much. We tore it down, we picked the pieces back up, and within about, I'd say, a month or two, we had found several of the errors that we had created, and we fixed them. We had the Lean team really working with us quite a bit during this time. And again, this is one of the slides coming up, but we went from 900 forms to 250, and this was one of the huge Lean team accomplishments in my view. I mean, when you just think about the waste that builds up, Family Healthcare has been in business for 30 years. Over that time, and as an organization, you don't necessarily look at when a new form comes out. It affects one department, but those forms over 30 years add up to quite a bit of waste in the system, and Lean was able to identify those, break them down, and get rid of several hundred, which when you're building an EHR, when you can eliminate things like that, it's huge. It does make things more efficient, and ultimately it makes your staff a lot happier. They don't have to track quite as much. It leads to more success. We did our pilots and staff training. We had refreshers. Of course, we went into scanning and ramp up, and finally we had our go live on March 2nd of this year. So, the next slide is just our EHR at a glance, and kind of gives you an idea of all of our different interfaces that we went with. We went big bang all sites, all modules in our EHR. So we did have a practice management, our lab system, our transcription, our RX eligibility, our Dentrix interfaces with our EHR. We also have CVIS, we have e-prescribing and e-faxing. Everything is on from day one on. So the engagement of Lean team into the multidisciplinary team that Norma spoke of earlier, we had just a huge team. I mean, I can't even when we first put this together, it was kind of looking like a nightmare trying to manage 45 plus people and their schedules. I didn't think it was going to work. I was scared. I really just, it wasn't something that I thought was going to be efficient, but what you get in return is you get a much better system because you have so many people with their real life experiences within your organization that it just can't help but make a better product at the end of the day, because and again, a key part of that is having staff that aren't afraid to speak their minds, because when you have that kind of interaction with people, conflict does end in resolution. And we found that there were several days we walked away kind of angry at each other, but by the next day we'd come back and say, yeah, you know what, you were right. And what you talked about yesterday was a better way of doing business. And so we did come to a lot of resolution through these different meetings and from interacting. And the great part was having frontline staff there and not just folks from leadership, because having the people that do this every day was a tremendous benefit to our team. They knew where the waste was, but oftentimes they'd never been given the forum to actually talk about it. And so one of the key things from Lean is being able to do that. We actually have one of our Lean members here. Would you like to talk a little bit about that?
It was a great opportunity, especially for being in the front line, to actually speak our opinion, because we do hear, we hear compliments from our patients, we hear complaints from our patients, and I actually had the opportunity to sit there and with 30 of us there actually, every complaint that we had, every compliment that we had, what they liked about the way that we did it, what they didn't like, we were able to sit there. I mean, we had over 300 Post-it notes. So we broke down everything, and we've seen what everybody else went through. So it was a great opportunity to actually sit there, and we broke it down from the actual time that the patient got up and picked up the phone to make that appointment. That's as far back as we went to, to break it down on how difficult it is for the patient to get through our line to actually just make an appointment, which should only take about a couple of minutes. So it was a great opportunity, and we came out with a lot of satisfaction for our patients and for us.
One of the things that really was an added benefit to all of this was a relationship that the leadership and senior leadership was able to build with frontline staff. We don't speak about it a great deal, but I think we all have a much better understanding of what our frontline staff do for a living, and I think the frontline staff probably have a better understanding of what we do for a living, because what we did was blend that very nicely into a very non-stratified relationship, and we all worked together. It was really a very nice situation, and it continues to this day to be a very nice situation.
So on the next slide, you'll have the role of the lean team, and the goal that's stated there is probably the best way of stating it. It really is preserving value with less work in the development of an EHR, at least in our case study that we're talking about now, because it's really trying to find the waste and get rid of it. I mean, an EHR is such a huge change to an organization that any type of waste that you can cut out is going to benefit you in the long run. We selected our frontline staff to make sure that they were vocal, they had initiative, global thinking, so they could kind of see beyond the next piece of the puzzle. So it really did help us when we tried to, and when we exposed them to the lean concept, it just was that much more of a benefit to us in the EHR level. We used it throughout the implementation, making sure that we identified the value, we mapped the value stream, we create the flow, establish the pull, and seek perfection. I don't know if we always found perfection, but we got pretty darn close on several things. So, and then of course a huge portion of this is bringing in the expertise, because in any large implementation, it's impossible to be an expert in everything, but when you can bring in those frontline staff that are experts in their area, you get a better product in the end. And then, of course, several people who were actually in our lean team, who were really only meant to be lean team members, ended up becoming core team members of our EHR team and went throughout the project and continue today as part of our team. The next slide will kind of break down the lean team details and the contributions that they had. You can kind of see that the lean team portion of it has 17 members. We tried to pull from as many different departments as possible, so we'd have as much interaction in different areas of our implementation as we could find. I believe we were successful in creating at least one person in each department, so we did have good representation. We provided key input on streamlining the current processes, and then again, you can see down there the example of reduction of forms from 900 to 250.
Jay?
Yes.
Hi, this is Karen. We have a question from the previous slide. I think on the cycle that you were describing. What does establishing the pull refer to?
Norma, do you want to answer that?
When Lean talks about pool, it's basically you want to pool the patient through the visit so that there's no bottleneck or they don't get tied up in the front. So basically, it's kind of like pushing the patient through that whole experience within the clinic. So you want to allow for processes that will not bottleneck or prevent that patient from being seen. Because their goal is to be seen by the provider. So how do you get that patient to be seen by the provider, and how do you eliminate bottlenecks or unnecessary steps and really help the patient pull through the process?
The initial concept of pull, back to the Toyota concept, was basically having the parts that you needed so that you could assemble the piece that you needed to assemble without having to wait to somebody go get me the part, somebody go get me the person who can do this. It was anticipating the needs of the next step, which is anticipating the needs of the patient in order to make their visit more efficient, to make their experience more pleasant, and to get them through quicker.
Great, thanks. That's a very helpful explanation.
Okay. So on our next slide, we have the Lean Team build-in decisions. Leadership team commitment was Tuesdays and Wednesdays as much as possible for the EHRs. And for the Lean Team specifically, they participated pretty much all day on Wednesdays, and this continued through our entire, well, for probably about 8 months we had these meetings. We did get to a point where we started pulling in subject matters as necessary. You know, at some point you have to get people back in the flow and make sure that they're out there helping our patients. But we did try to keep them together as often as we could because, again, having all those different people with different opinions on issues was very beneficial to us. So they participated primarily in workflow design, system build, workflow testing. We did do PDSA, and then again, communication of changes to staff they participated in. We also had, of course, weekly calls with vendors on interfaces. Lean Team didn't necessarily have a huge input on that portion, but we did have a couple members who crossed over into different teams, and so they might be on Lean and they might be on design, for example, which worked a lot with the technical issues. On the next slide, you can kind of see our training and support. The trainers were active as of last August, and they participated in build-in decisions. One thing, we do have an in-house training department. It was important to us at Family Healthcare that we made sure that our employees learned the Family Healthcare way, not our EHR vendors' way of doing business. And so this was one of the things that we wanted to make sure that, again, that we had a very thorough training for all of our employees so that when they started using the EHR, they felt comfortable and it was something that worked within the way that they did their job. So you can kind of get an idea of the modules that we had and the participants. We also trained a lot of our providers and PCA teams together. This was done as one of our strategies so that if a provider needed some further assistance, the PCAs would have been in the training with them. They could assist, or if it was the PCAs that needed some assistance, the providers would be there to help. So we try to keep that team together as much as possible.
Okay, we have another question. Somebody asked about the clinicians on the Lean team. Were there clinicians on the Lean EHR team, and if so, how did they manage being out of clinic for a full day, like on the team, the Wednesday Lean team days?
Yeah, this is Dr. Palmer. We had clinicians on the Lean team, and indeed they were out of clinic at various times. We understood that would happen. We were willing to absorb their patients, or other providers were willing and able to absorb their patients, so there really wasn't any kind of a drop in productivity at that time. And our clinicians were medical directors who also practiced, so they had some flexibility in getting out of the clinic. We did later on have super users who were physicians, and they did sacrifice probably a day or two out of the clinic for additional training, but there really wasn't a problem in terms of having the providers out of the clinic.
Thank you.
So as Dr. Palmer said, we did have super users. This is something that we've used for the last few large implementations we've had in technology, dating back to our practice management system. And so we try to do as much as we can for our employees as far as having different modules, having super users available. We had scenario training that we sent out on a regular basis to providers. And again, the Lean team had a portion of this. This was something that they were able to participate in when we were actually developing the training material, helping to, say, well, do we really need to have that step here or there? and really assisted our trainers in creating very strong modules for our staff. The next slide is called Getting Ready for GoLive. This is one of those slides we have in our EHR presentations as well, and this is probably one of the biggest things that we did as a team. It really contributed quite a bit to our success. And what ramp up means to us is that basically from the week of February 8th through the 31st, through the 1st of March, we increased the amount that our providers use the EHR. In other words, during these weeks they were doing double entry. So on 2/8 they saw 25% of their patients in the EHR, and they also documented in the paper chart as well. And what we were able to find during this time is that we were able to clarify and train, do check-offs of providers to make sure that they felt comfortable with the EHRs. We found several issues that needed to be addressed in build and templates. We were able to stress test our hardware and our servers, and then we were also able to do failover testing. We increased these by each week, so there by the second week the providers were seeing 50% in the EHR, 75% in the third week, and 100% right before GoLive.
We also incentivized our providers by offering 2 days off additional to their vacation bank for the first 10 providers who were able to complete 75% of their patient visits in the EHR and complete them correctly. And we had about 15 people who did that, so we had to do a random draw in order to comply with the 10 providers. But it really went very smoothly. By the time we reached 100%, or prior to reaching 100%, providers were saying, I'd really rather not even bother with documenting in the chart. I just want to go ahead and use the EHR. And of course, we were not live at that point, so we had to continue double documentation until the go-live date.
So part of this was, as I mentioned earlier, we went big bang, all modules, all sites, and our vendor was very against this. They wanted us to do site by site, module by module, drag this out basically over 2 years. We did not do that, and the go-live was part of that success. So one of the fun things about this was that they sent out a huge team to be with us for go-live. They were very concerned. They thought that there was going to be a lot of problems. I believe we had about 10 people from that vendor on-site ready to assist. And then on March 2nd when we went live, we didn't even have a hiccup. There was nothing. Basically, we sat in a boardroom all day looking at each other and giggling, and by the end of the day, we realized that we had a very successful implementation, and the ramp-up definitely contributed to that. On the next slide, you can see our go-live numbers for March, how many visits we were doing in a day. To give you an idea, there at the bottom on March 3rd, maybe the day after, we had 1,936 visits. You can see our lab orders, our prescriptions, our referrals, our in-house radiology ordered, our telemedicine services ordered. And we did have super users at all sites providing support and communicating sessions where we basically meet as teams to talk about issues that have been coming up. Those were pretty short. It worked out really well. And then, of course, on the next slide, you can kind of see our March 2010 numbers. This actually gives you March 1st through the 16th. You can kind of see a very nice pattern there that did not change from our go-live of March 2nd. Just kind of keeps on going. Just to give you guys an idea, on those Saturdays, we're only open part day, so Saturdays are always low numbers for us, so those aren't out of whack.
Dave, we have a couple of questions.
Okay.
So the first question is, a couple of people have asked about which EHR you chose. I wonder if you could talk a little bit about IC Chart.
Sure. We chose Med 3000. Med 3000 is a company. Integrate EHR is the product, and it's not one of the big name EHRs, but the reason we went with it is because of how intuitive the product is. We went through almost 2 years of trying to decide on which product we wanted. We looked at the next gens, the GEs, the Allscripts, and the eClinical Works of the world. But at the end of the day, we had numerous occasions where we actually had tablets loaded with the products on site for providers and frontline staff to use. And unanimously, almost all these things, Med 3000 continuously won out on the surveys. And so it was one of those things where, you know, it just was very easy for you to pick up, and it was easy not only for the providers but frontline staff. Everybody just seemed to enjoy the interface. It was the least amount of clicks that we could find. It was one of those things where when you look at building templates, providers can build their own templates. You didn't have to hire programmers to do it, which was important to us. The reporting capabilities in it are very good. The actual vendor itself is a true partner, and when I say that, just to give you guys an example, when we were going live in December, Dr. Palmer discovered that there was a problem with our OB module. He did not like it. It was not something that he felt was going to be a very popular thing with our OB providers. It just wasn't there. It didn't follow certain criteria that he was hoping to see, and so this vendor changed the entire module for us. They made it look just like the ACOG forms that most OB providers are very familiar with, and hospitals are familiar with. And so now that module is perfect for us. And I just can't, I mean, my background is in software development, and I can tell you that I've never seen a vendor do that for a customer like Med 3000 did. They really do understand what it means to be a partner, and whereas if you have a GE or a next gen, you're a very, very small fish in a very, very big ocean. So we've never had that feeling from Med 3000.
Thanks. And we have one more question. Somebody asked, did you document any test environment? I'm assuming this was before GoLive.
Yes. We do have a test development that basically has, that we worked on through most of the implementation. So we actually had that test environment up in August, and we worked off that until February.
We're still using the test environment now. As we get updates, we always run them through the test environment to make sure that what we're getting, we're happy with. And once the update passes through the test environment, we actually transfer it up to the productivity environment. So it's invaluable to have a test environment. Obviously, you don't want to do this in your permanent records before you know it's right.
Thank you.
So continuing with the slides for today, you can see on 9/1, again, we're right in that same range, 1,944 visits, 9/15, 1,977 visits. I mean, it's just been really a no impact to productivity by having the EHR. We heard about it the entire year. Our vendor pleaded with us at one point to reduce our visits by 50% for the first 6 weeks. We refused to do that. It was one of the strategic goals of our team not to reduce productivity when we implemented the EHR. It was very successful. It was largely due to having a group of people to work with who was dedicated to this project from day one, and having things like Lean incorporated into it just made it that much better for us in the long run. And then the next slide, you can see there's the entire month of 2000, for most of it, 2010. Just again, you can see that same kind of pattern of numbers, just very balanced. And that's it for the case study.
This is Marisol again. I'm just going to finish it off. You heard about the case study, and we still continue to use the concepts of Lean, but I also want to interject that we also use PDSA as well. But really going back to what we feel Lean is to us, and utilizing those concepts when we do an improvement project here at Family Healthcare Network. There are challenges to lean. It does take resources, and you've heard that. It is an investment, though, for any improvement project. And some of the things that we've identified as sort of gaps that we still need to work on in the challenges of lean is just learning more. QI terms and concepts, they're new to people, as well as the lean terms sometimes can be confusing. We talked about the DMAIC, and there's value added versus non-business value added, but really, teaching it in a way that it makes sense to their everyday duties, scope of work, the process that they're working in every day. And I think that that's what made it very successful in the EHR. As well as a whole organization, really looking at change management, and everyone needs to skill up on project management as well. So those are still some of the challenges of lean, but I think we had a pretty successful run-through. So on our ongoing journey, and what we plan to do next is really to identify staff and I like to skill them up, because we utilize lean in very large projects, organization-wide projects, but these concepts can also be used at the department level, within your individual day-to-day work. And so really skilling up coaches at individual sites where they can do projects on their own as well. And again, aligning all of our organizational behaviors. I think that you heard that through the presentation that, as managers, sometimes we think, this is the way it should be done. And we had folks that were empowered, that had new skills, had brought skills to the table, and they were really helpful to the process to critically think through and to think beyond the box. But, and it was challenging at times, as Dr. Palmer said, but I think in the end, the product is about the customer and about our employees as well. And again, we really want to introduce some workshops for staff, new hire orientation, again, so everyone has these skills. So when we say lean, everyone knows what we're talking about at all levels. This shouldn't be a new concept to anyone. This is the way we think here.
Great. Thank you very much for an excellent presentation. So now we'll open it up for question and answer. You're more than welcome to use the raise hand function or to send me questions via the chat function. We already have a few questions for the presenting team. The first question is, which employee survey and patient survey were used to get the voice of the customer?
Human Resources had launched an employee service through the Quality Improvement Department 2 months prior to the consultant coming on board. So since that had been recent data, we used that. And in terms of the voice of the customer, there was two things. There was the monthly patient satisfaction surveys, but we also did a separate survey where we selected randomly 100 patients that had been seen in that previous month, and they were contacted.
Thanks. And then we have another question. Who led the lean team? Like, who kind of managed it, as well as, like, who, for example, facilitated the Wednesday team meetings?
That began with our black belt, the person that we had hired. Once she was finished, it sort of sustained itself, I really have to say. We all had a hand in it in terms of maintaining the lean mindset. As a matter of fact, it became almost a joke, because anytime something was suggested, the next sentence would be, "Is it lean?" And we always, hearken back to that. But once it had begun, it actually had a life of its own, and still does, because we tend to think of almost everything we do in lean concepts. We're currently planning to transition to a patient-centered health home, and we're looking at that in terms of lean concepts as well. So the team was sort of managing itself, but it was still part of the implementation of the EHR.
Another question. Oh, go on.
No, I was just saying, the lean team actually blended into the EHR, but the EHR itself had a project manager. I don't know if that was the question, but as far as lean, again, I think Dr. Palmer's right that it took a life on. I mean, they were the lean team in EHR.
Another question is a little bit longer. Let's see. For those processes that you worked on eliminating waste, how did you spread those new processes to other clinics? How was it in those clinics that were not engaged in the improvement, but rather had the results of the new process given to them after being developed by the initial clinic?
Well, all of our processes were engaged in all of our clinics. It wasn't as though we did it within a vacuum. Even though we have 11 clinics, we didn't create it in Clinic 1 and then spread it to Clinic 2, 3, 4, 5. The lean team was drawn from all of our clinical sites so that when we did make a change, it went throughout the system.
Okay, and we have a participant who'd like to ask you a question. Peter Del Florentino. You're unmuted. Peter, do you have your hand raised?
Right. Yeah.
Can you hear us?
Oh, this is Miles Shaver from Contra Costa Regional Medical Center. I'm in Martinez, California. Under Peter. Sorry.
Okay, we can hear you.
Yeah. So I'm just looking at your visits per day and your poll production. I also had a question regarding that also. So I've listened to what you guys have stated, and I'm just interested in case studies as far specifically related to patient outcomes and patient-centered care. So how is your system, as far as your poll production, has that improved patient visit times, patient outcomes, your satisfaction surveys post-implementation? And then also, I guess that's my first question, if you can answer that.
Well, in terms of wait times, I can tell you that a year ago our average wait times were about 35 minutes. As of last month, we were down to 20-minute average wait time network-wide. And we're still implementing some of the recommendations that came through from the Lean team. So for us, it's an ongoing process, but we've already seen a significant improvement in our wait times.
And I guess my other question is, oh, go ahead, sorry.
As far as patient satisfaction, we did see a slight, honestly, I'll be honest, we did see a slight decrease for that month of March, but it's gone up and we've sustained it.
And as far as your visits per day, are you looking at just sustainability as maintaining those visits, and in the future are you looking at increasing the amount of visits per day, I guess?
We plan on having about a 10% increase annually in the number of unique patients that we serve. So the answer to your question is we're increasing visits per day.
Thank you.
There was another question from Contra Costa. You made a difference between a lean team and a core team. What was the difference between those?
Okay, well, there's actually 4 teams, but a lean team was the lean team. We had a build team that worked basically on templates and workflow. And again, please remember that a lot of these teams work together. So even though they were broken up, but oftentimes it was all 4 groups working together. We had a design team that was more of a technical team, and then we had the core team. Core team was made up of leadership, a few supervisors that we pulled in that were kind of a system experts. We had some frontline staff. The total core team was 14 people. It was meant to be smaller. It's a kind of a decision group so that, when there had to be decisions on whether or not we proceed with a certain template or a build, that this is the team that pushed it forward or not.
And a second question, did you scan documents into the system and in addition to creating original documents electronically, or was it all scanning?
No, it wasn't all scanning. We have access to our previous dictated information electronically. So all that was electronically downloaded into our system. We have information that needs to be scanned, which comes from outside of our system, and they are scanned and indexed into our EHR. We do not dictate at this time. All of our documentation, all the documentation done by providers and clinicians is done through the EHR in a template form, so that scanning is just limited to outside laboratory comes in electronically, but outside radiology reports and outside consultation reports.
Thank you.
We do maintain paper forms, but for the most part, we're turning those electronic.
Thanks, Contra Costa. We have a couple more questions that we'll try to get to. One question is, was anyone in the lean team part of the vendor selection process?
I believe all of them were. So, again, we had all of our, basically all sites had the opportunity to go and view the products. We had vendor demonstrations, and we also, again, we had actual laptops on site where staff could come in, they could play around on the system without the vendor sitting there, and then rate each EHR based upon how they, felt about its functionality, its intuitiveness, how they ease of use, amount of use. We had several different criteria that we were interested in getting staff feedback on.
And then the next question is, how much time was initially spent in education of the team prior to the formation of the lean team? Also, who served as the project manager of the team?
Well, the education of the lean team was done at the time they were selected. It was explained to them by the resource person that we had hired what lean was all about. They had an orientation to lean. They understood what they were getting themselves into. They understood that what they had to say was not going to be held against them in court, and they wouldn't be judged by their supervisors for making a comment that might be contrary to what the supervisors were thinking. But it was an ongoing process of education and doing, so it was all done at the same time.
Great. We have time for one more question. Let's see. What role did your quality managers play in the process?
In the initial lean process that Norma talked about, the wait time, it was, it was almost like a pilot of the lean process. And so many of the managers weren't involved. It was really this frontline multidisciplinary team. Now, when we went into HR, I was part of the core team and part of the process.
Okay, and then I guess it wasn't clear to the person who asked the earlier question about who was the project manager of the lean team?
Well, there wasn't really a project manager of the lean team. There was a coordinator of the lean team. That was a person that we had hired who was a black belt in lean. As I said, she wasn't here forever. She was here for a couple of months, and then the lean team pretty much became part of the EHR team. They were involved in development. They were involved in advice and consent about what we were doing in terms of developing the EHR, and as such came under the jurisdiction, I suppose, of the project manager of the EHR. However, the project manager of the EHR did not control the lean team in any way. They were just part of the team.
Great. Well, thank you so much, Dr. Stephen Palmer, Jay Kelly, Norma Verduzco, Marisol de la Vega Cardoso, and Adriana Carrillo from Family HealthCare Network. This was a great presentation, and we thank you for your time. And thanks to everyone who joined the presentation. We will send the URL at which the recording and the slides will be posted.